بسم الله والصلاة والسلام على سيدنا محمد وعلى آله الطيبين الطاهرين وأصحابه المختارين. السلام عليكم ورحمة الله وبركاته. In this lecture, we are going to talk about hyperkalemia in massive blood transfusion. Hyperkalemia is one of the massive transfusion complications. Risk raised sharply when transfusion multiple units of rapid packed red blood cell as in massive transfusion protocol for postpartum hemorrhage. Hyperkalemia is the result of massive blood transfusion, where potassium leak in stored red blood cell, rapid infusion of large volume, hemolysis, poor renal clearance in shock status, and acidosis. Older or radiated unit containing higher extracellular potassium. Risk rise sharply when transfusing multiple units rapidly, as in massive transfusion protocol. Management require calcium for cardiac protection, insulin and glucose to shift the potassium, correction of the acidosis, and avoid of hemolysis. What happened here, the hyperkalemia is life-threatening complication of massive transfusion and rapid infusion of stored blood product. Why it's happening in massive transfusion protocol, or when you massively and rapidly transfused blood. Potassium leak in stored red blood cell. During the storage of potassium leak outside the red blood cell into the preservative solution. Rapid infusion of large volume exceeding the clearance in the urine. In addition, into the poor clearance in shock and acidosis. Hyperperfusion, acidosis, renal dysfunction, reduced potassium excretion. Hemolysis, releasing of intracellular potassium from lyzed red blood cells significantly raise the potassium. So high potassium in older or irradiating blood. As the blood is older and more irradiated, the unit containing higher concentration of potassium. Usually, the normal serum potassium shouldn't exceed 5.5 millimole. Potassium load from the blood product, if we said packed red blood cell stored more than 14 days, it will be 20 to 40. Fresh frozen plasma around 5. Platelets 2 to 5. Cryoprecipitate 1. So normal serum, as we said, potassium is between 3.5 and 5 millimole. If it is exceeding 5.5, then it is hyperkalemia. How we are going to manage hyperkalemia? First, we have to do cardiac protection. We give calcium gluconate as the one we give it in the hypocalcemia, 10% in 10 ml IV over 10 minutes. Protect the heart membrane but doesn't lower the potassium. So to lower the potassium, you have to shift the potassium from extracellular to intracellular space. So insulin regularly 10 unit IV plus dextrose 25 unit of 50% glucose. Once the onset will be 15 to 30 minutes, the duration it will cover around 4 to 6 hours. So every 10 units will cover around 4 to 6 hours. This will lead to shifting of the insulin, and the insulin will be shifted with the dextrose to intracellular, and it will drag with it the potassium. Correct acidosis, treat underlying acidosis, example, sodium bicarbonate in severe metabolic acidosis. Remove the potassium from the body. Loop diuretics, the furosemide, if the urine output is adequate. Consider dialysis if refractory or there is renal failure. A lot of cases there will be acute renal failure during the massive blood transfusion. Prevention and avoidance, use fresh blood less than 14 days, avoid hemolysis, avoid irradiated blood, monitor the potassium closely during the massive blood transfusion. Monitoring serum potassium frequently every 30 to 60 minutes, and monitor the ECG, correct the hypocalcemia and hypothermia and acidosis. The recognition the prompt the management and the prevention of care to prevent arrhythmia and save lives. What is the risk factor? Massive transfusion, as we said, massive transfusion protocol, activation, rapid infusion, more than 4 units of packed red blood cell, use of older blood, more than 14-day, irradiating blood products, and hemolysis and traumatic transfusion, shock, acidosis, and hypothermia, renal impairment, and high risk in obstetrical hemorrhage require massive transfusion. How this, if there is hyperkalemia, how it will be presented? It will be presented as progressed, it may be presented with the ECG changes, a peak T wave, wider QRS, prolonged PR, P wave flattening, sinusoidal pattern in severe cases, and may progress to ventricular arrhythmia or asystole. Cardiac arrhythmia, hypotension, cardiac arrest, muscles weakness or paralysis. Metabolic acidosis worsening the potassium retention. Hyperkalemia in massive transfusion, acute treatment and prevention. How we are going to do prevention? By doing electrolyte, sodium potassium bicarbonate every 30, in addition to PTPTT and coagulation factor, every 15 to 30 minutes. And once you identify that the potassium is increased, you have to acutely treat the potassium. We talk about the stabilization of myocardium by giving potassium gluconate, calcium gluconate, 10 ml and 10% over 10 minutes. We talk about also shifting the potassium to intracellular by giving insulin 10 unit with 25 gram glucose, or you give nebulized salbutamol 10 to 20 milligram. Also consider giving bicarbonate in such cases to correct the acidosis because the high H ions in the extravascular space will preventing the potassium from shifted. So by giving the bicarbonate, the iron will be moved to inside the cell, and the bicarbonate will be equalizing the acidosis. Removing the potassium from the body, diuretic if perfusing is adequate, and hemodialysis in refractory cases. Continuous ECG monitoring is essential until the potassium normalizes. Target serum potassium between 3.5 and 5 millimole per liter. Can we prevent hyperkalemia? Dig deeply to the causes. What causes hyperkalemia? Do the opposite. Old blood is one of the things which is cause hyperkalemia. So use fresh blood less than 14 days of age and avoid storage more than 20 to 30 days. Avoid excessive pressurization causing hemolysis. So transfuse with the lowest effective rate considering with the clinical need. Monitor regularly every 30 to 60 minutes. And if there is any sign of hyperkalemia, you have to correct it. Maintaining adequate perfusion, oxygenation, and urine output. Also, correct acidosis, hypoperfusion, and hypocalcemia. The fact worsening the hyperkalemia is the hypocalcemia and acidemia. So it has to be corrected. If you did all these things, we are hoping that this is going to reduce the incidence of hyperkalemia in massive transfusion protocol. Why hyperkalemia occur in massive transfusion protocol? We said that the impaired potassium handling due to shock, hemorrhagic shock lead to reduce the renal perfusion, and this will lead to metabolic acidosis, and in the kidney cannot clear the potassium effectively, and accumulation of potassium in the blood. How shock impairing excretion? Once the patient in shock, reduce the renal blood flow, reduce glomerular filtration rate, and this will reduce delivery of sodium and water to the distal nephron and reduce potassium secretion. Oliguria and urea lead to potassium retention. Severe shock plus tissue hypoperfusion exacerbating hyperkalemia risk. The clinical impact of shock, even if moderate potassium load from the transfusion, blood can lead to severe hyperkalemia when the kidney cannot excrete it. Acidosis is play important role in the development of hyperkalemia. We have a separate lecture about acidosis, but you have to know that the metabolic acidosis causes extracellular shifting of the potassium. Even normal potassium load may resulting in the hyperkalemia and acidemia. So there is high ion because of acidosis, high H, and this will lead to shifting for the H inside the cell, and the cell will get rid of the potassium to outside, and will lead to hyperkalemia. The common cause of acidosis in the postpartum hemorrhage, we said that there is tissue hypoperfusion, they are using anaerobes, and it will be lactic acidosis will be accumulated. Hypoxia, renal hypoperfusion and renal failure, low pH, large volume transfusion, and will be impacted clinically on acidosis, affecting the hyperkalemia and affecting the heart and cause arrhythmia. Correcting acidosis helps shifting the potassium back into the cell and lower the potassium level, and early recognition and the treatment of acidosis is crucial in massive transfusion. So the key message, shock reduced renal potassium excretion. Acidosis shifted the potassium out of the cell. So both mechanisms act together in postpartum hemorrhage. Potassium accumulation, risk of life-threatening arrhythmia develop. Early recognition, timely intervention, going to save life. Thank you for your commitment to excellency in women healthcare. Together we are shaping safe care, improving outcome, and supporting every woman at every step.